Just taking this forward again, I was asked to talk about 10 principles of management of acute physeal injuries. Let's look at a case straight off. This is a 2-year-old proximal femoral neck fracture, and I think we saw this earlier in the morning. How do we need to go about managing this case? It's a Salter-Harris 2 fracture, as Vijay alluded to in his talk. This was treated in a sling and went on to remodel nicely. So what we need to remember is that proximal humerus and distal radius are the 2 places where maximal growth is happening. And if the child is young, there's a very high chance that these are all going to go on to remodel, and we need to be aware of the age and the site of injury in every patient with a physeal injury. So know the growth potential, that's principle number 1. So another fracture, this is a slightly older child. So again a Salter-Harris 2 distal radius. The surgeon tried to manipulate this, couldn't get it in one attempt, tried various attempts to reduce it, and finally got this position. Later went on to have a growth arrest. And so principle number 2 is you want to avoid repeat attempts at reduction. So what really happens is that the metaphyseal fragment has a spike, and it can rub across the growth plate and cause scraping and damage to the germinal layer. So malreduction is anytime better than growth arrest, and especially in the distal radius proximal humerus where there's potential for growth. Don't do repeat attempts at reduction, and don't damage the physis. Also in the distal femur and the proximal tibia, the growth plate is undulating, and if we try and manipulate these fractures, the undulating physis has a higher chance of getting a growth arrest. So this is another boy, 12-year-old, Salter-Harris 2, distal tibial fracture. And when we try and reduce this fracture, the reduction is often unstable and you want to fix it. Principle of fixation is that you always want to fix metaphysis to metaphysis and epiphysis to epiphysis, and avoid going through the growth plate because that's the sensitive area. Another fracture, this is a type 3 fracture with associated talar fracture, and all those fractures which have intra-articular extension really need an open reduction to align the articular surface as well as the growth plate properly. So this child underwent open reduction and fixation with the trans-epiphyseal screw in addition to the talar fixation, and later went on to have healing of the fracture without getting a growth arrest. When you have type 4 Salter-Harris fracture, you want to fix metaphysis to metaphysis and epiphysis to epiphysis. And again, if you have accurate reduction, you can get away without getting into a growth arrest. Open reduction really is required in these type 4 Salter-Harris and type 3 Salter-Harris injuries. And you want an incision which will visualize the articular surface adequately. So it needs to be positioned in that manner, and the fixation again needs to be in a manner which does not compromise the growth plate. For these fractures, when you reduce these fractures, it's important not to put in jigs and levers across to lever the fracture out, and you want to really try and do a joystick kind of a maneuver by which you can manipulate the fragment and put it back in place. So another principle is to avoid direct pressure on the growth plate while trying to do an open reduction on these fractures. Well, you can't always fix these fractures without traversing the growth plate, and there are some of these injuries in which you will need to go across the physis. And some principles of fixation of these fractures when you need to go across the physis is that you want to first use smooth pins. You don't want to use big screws across these because they will definitely hamper the growth later on. So after you've decided to fix these fractures, you want to stay central. Try and avoid the peripheral part, which is the perichondrial ring, because this is a fibrous zone which binds the metaphysis, the growth plate, and the epiphysis, and is highly likely to produce a physeal bar in that region. Also, you want to use minimal required pins. So don't fill it up with pins to get a lot of stability, as Dr. Crawford alluded to in one of his earlier talks earlier, where a lot of pins were passed and you get a growth arrest. So minimum pins, and you want to use the least diameter or thinnest pin possible, which will provide fracture stability. And then you want to supplement it with a plaster fixation or a cast to help you keep the fracture reduced. Also, you want to avoid multiple passes and keep pins for the least possible duration, again, to prevent growth arrest. Well, then there will always be late presenters, children who don't present on time, and it's important to remember that these physeal injuries go on to heal really quickly. So if about 7 days have passed, it's probably too late to reduce these fractures, and you want to leave the type 1 and type 2 Salter-Harris fractures alone. For the type 3s and type 4s, if there is displacement and articular incongruity, you want to reduce these fractures, because incongruous articular surface will predispose to premature arthritis. So here's a 3-year-old child with an intra-articular extension of a physeal fracture. Came in about 2 weeks from injury. And we got a CT scan, and you can see that there is a transphyseal fracture which is extending into the metaphysis, and it's displaced. So this child underwent open reduction and fixation with smooth pins, went on to heal, and at about 2 years follow-up, there's no evidence of a growth arrest at this present time. Well, we need to follow these children up for a long period of time, because growth arrest, as alluded to, is the biggest problem. You want to repeat x-rays in 5 to 7 days. That's to check for interval displacement. And you want to follow these children at 3 months, 6 months, and 1 year intervals. And what you want to really look for is the Harris growth arrest lines, which give you clues to a physeal arrest. This is a boy with a type 3 Salter-Harris fracture. It was treated in a cast and went on to develop a physeal arrest. This is him at 2 years post-injury, and you can see a varus deformity at the ankle. We got a CT scan, and that shows a physeal bar. The physeal bar needed to be resected, and an open wedge osteotomy was done, and which led to restoration of growth, and this child went on to do well. Well, the final point to remember is that we need to explain the prognosis to the family, because these are all injuries which will potentially can cause growth arrest. So we need to prognosticate them. Severity of the injury, so high velocity injuries are definitely worse. Older children, children less than 13 years have more growth potential and have a higher chance of getting growth arrest and limb discrepancies. The distal femur and proximal tibia are worse sites because they are undulating physis, and the type of fracture, the Salter-Harris 3s and 4s, which go across the physis, can cause higher chance of growth arrest. And if the child comes in late, those are worse problems, because you are probably not going to be able to reduce those fractures. And when we try and reduce and fix these fractures, if you go across the physis, there's definitely a chance of causing a growth arrest. So I think we need to remember all these points.